many clinicians feel stuck when it comes to insomnia treatment. You might prescribe a medication or recommend sleep hygiene, and the patient comes back still not sleeping. Or they might tell you, I've tried everything, medications, supplements, CBTI, wearables, and nothing has helped. So after seeing enough insomnia patients, you start to notice a pattern. The more someone tries to force sleep, the worse their insomnia becomes. And sometimes, without even realizing it, you as the clinician get pulled into that same cycle. You might be trying one medication after another, or trying one behavioral strategy after another, and then the whole visit turns into what I sometimes call the dance of sleep effort. And that feeds into your patient's vicious cycle of insomnia. So in this video, I want to show you 4 shifts that can completely change how insomnia treatment works in your clinical practice, even for patients who have struggled for years. And I'm also going to share what to say when your patient asks you for another sleeping pill. This video is part of a short insomnia series for clinicians. In the previous videos, we talked about why insomnia becomes chronic and how to evaluate it. Today, let's talk about what to actually do in your clinical practice. I'm Dr. Nishi Bhopal. I'm a psychiatrist and sleep medicine physician. On this channel, I teach clinicians practical ways to evaluate and treat sleep problems in everyday practice. You can also earn CME credits for these videos through Learner Plus, and I'll include that link below in the video description. Alright, so one of the challenges with insomnia is that many clinicians feel like you only have 2 options: prescribe medication or refer for CBTI, which is cognitive behavioral therapy for insomnia. A clinician once told me, I feel like every insomnia visit turns into a negotiation over sleeping pills. And I get that. Your patients are exhausted, they want relief quickly, and as the clinician, we often feel the pressure to solve the insomnia in a single visit. But insomnia does not work that way. Sleep can feel more intangible than other medical problems because there isn't necessarily one lab test that tells you what's wrong or what to do next. So this is why having a clear framework for insomnia treatment makes such a difference. If you're a clinician who would like a structured way to approach insomnia, I've put together a short free clinical mini course for healthcare professionals. So I walk you through a clinical framework step by step. You can get that at intrabalance.com/doctors or using the link below. Okay, so in my experience, most insomnia treatment becomes much clearer when you focus on 4 main areas: stabilizing circadian rhythm, rebuilding sleep drive, removing sleep disruptors, and helping patients change their relationship with wakefulness. Okay, let's walk through each of these one by one. The first place I usually start with in treatment is stabilizing the circadian rhythm. Good sleep starts during the day. This includes morning light exposure, regular movement, consistent meal times. These anchors help stabilize the brain's sleep-wake rhythm. So let me tell you about a patient that I once worked with who was in her 30s. She had severe clinical insomnia, and she was prescribed high doses of sleeping pills that just weren't working, and she was desperate for relief. And I found out that she was skipping meals, she was doing intermittent fasting, she was training intensely because she was an athlete. And so she was interested in something very concrete to start with. So we began with something very simple, which was regular meal times, using lunch as her anchor. And within about a week, she started to notice an improvement because her sleep-wake rhythm began to feel more stable. And for the first time in a long time, she felt something which is really important in insomnia treatment, which is hope. But stabilizing the circadian rhythm alone rarely fixes the insomnia, because another factor is something that many clinicians accidentally weaken when trying to help patients, and that factor is sleep drive. Sleep drive works a lot like hunger. So if you have a snack right before dinner, you're not going to be as hungry when it's time to eat. Sleep works the same way. If someone spends too much time in bed, the brain doesn't build up enough drive for sleep. So I once worked with a woman in her 50s. She had struggled with insomnia for many years. She was prescribed lorazepam by her primary care physician, but she didn't want to rely on it, so she came to see me. And she had decided that the way to fix her insomnia was to go to bed earlier. So she started going to bed at 9 p.m. every night, even though she didn't fall asleep until midnight. So she was lying awake in bed for 3 hours every single night. So over time, this resulted in a very predictable pattern, which is her brain started associating the bed with wakefulness and frustration. So this is what we call conditioned arousal. You'll often hear clues about this when patients say things like, I'm exhausted all day, but the moment I get into bed, my brain wakes up. So instead of going to bed at 9 p.m., I moved her bedtime later, closer to when she was actually falling asleep. Within a week or two, she began falling asleep more easily because her brain had rebuilt stronger sleep drive. But bedtime is not the only thing that disrupts sleep. Sometimes the problem is hidden in everyday habits that undermine sleep physiology. Another step is identifying sleep disruptors. These are things like alcohol, heavy meals at night, caffeine late in the day, a sedentary lifestyle, lack of light exposure during the day, and a lack of darkness at night. All of these factors. And there's more, but these factors negatively impact sleep. When you remove them, sleep often improves more quickly than patients might expect. But one of the most powerful shifts in insomnia treatment isn't behavioral, it's psychological. And this is something that I learned in an unexpected way, in a more personal way than I would have thought. During my sleep medicine fellowship, Thursdays were our sleep study reading day, so there's no clinic on Thursdays. Early on Thursday mornings, I would take the T into Cambridge and go to the Harvard pool for swimming lessons. You could smell the chlorine as soon as you walked inside. And I was learning to swim because my husband loves scuba diving, and we were about to go on our honeymoon. And the problem was that I have a phobia, was that I was afraid of deep water. It was like a phobia. So I remember standing at the edge of the pool thinking, how am I going to overcome this before the honeymoon? And when I first got into the water, I was pretty tense. I was kicking, thrashing more than I should have. I was trying really hard to stay afloat. And the harder I tried, the more I sank. My coach was super patient. She was smiling and saying to me, okay, just breathe, relax, let the water support you. And over time, I was able to trust the process, and then it clicked. When I stopped fighting the water and trusted that it could support me, I could finally relax and float. It became effortless. Sleep works in a very similar way. The harder someone tries to force sleep, the more alert and fearful the brain becomes, the more the brain starts thrashing around. And there's a quote I love from Gillian Flynn, who's the author of the book Gone Girl. She wrote, "Sleep is like a cat. It only comes to you when you ignore it." And that is so true. So I once worked with a patient who had been waking up in the middle of the night for more than 20 years. And he had sleep apnea that was already well treated. He had tried multiple medications. Nothing seemed to help with these nighttime awakenings. And by the time he came to see me, he said his bed was a battleground. So he dreaded bedtime. And what became clear over our work together was that the biggest factor driving his insomnia was not another sleep disorder, but it was his relationship with being awake at night. So we worked on something very simple but powerful. Instead of trying to eliminate that wakefulness completely, we practiced allowing it. If he woke up at night, the goal wasn't to fight that. The goal was to let the experience be there without feeding into the anxiety. And he was actually pretty shocked by the results because after 20 years of struggling, when he stopped battling that wakefulness, his nervous system began to settle and sleep started to come in naturally, like that cat coming to you. And he was most excited not only that he was sleeping better, but that he had more energy during the day to spend time with his grandchildren. So even if you as a clinician, even if you know all of this, sometimes the hardest moment in these visits is when a patient says to you, "Can you just give me something to knock me out?" And in these moments, I'll often say something like this, and you can steal this for your clinical practice. Medication can sometimes help in the short term, but if we rely on medication alone, we're not fixing the system that produces sleep. So my goal isn't just to help you sleep tonight. I want to help you sleep well months and years from now. Then I ask their permission, would you be open to exploring a few strategies that tend to work better long term? When you use this method with patients, most of them are relieved that someone is actually willing to help them, and they're usually more open to trying some of these other strategies. And I remember one of my attendings when I was a new psychiatrist and new sleep doctor telling me that the biggest difference between a junior clinician and an experienced one isn't just knowledge, but it's the patience to allow time for treatments to work. Insomnia treatment is kind of like turning around a big cruise ship. It doesn't change direction instantly, but these constant, small, consistent adjustments do start to change the trajectory. And helping patients understand that reduces a lot of anxiety around sleep. We're setting the expectation that we're talking weeks, not just days. And we have to allow time for things to work with small incremental changes consistently and have that patience. And it's our job as the clinician to hold that space for the patient so we're not getting caught up in that dance of sleep effort. So the 4 shifts that you can use to change insomnia treatment are stabilizing the circadian rhythm, rebuilding sleep drive, removing sleep disruptors, and helping patients change their relationship with wakefulness. The goal is not to force sleep. The goal is to create the conditions where sleep can happen. If you have a colleague who feels stuck with insomnia visits, share this video with them because these 4 shifts can make those visits much easier. I'll see you in the next video.